Welcome, everyone. I am Chris Perrone, Director of Improving Access to Coverage and Care at the California Healthcare Foundation, and I'm delighted to be kicking off today's webinar, Making Telehealth Work, Key Insights from the Safety Net. At the California Healthcare Foundation, we are pursuing many approaches to ensure that our state's 14 million Medi-Cal enrollees, 80% of whom are people of color, have timely access to high-quality primary, specialty, and behavioral health care, and to close the gap between access to care for Medi-Cal enrollees and Californians with private coverage. One approach we believe must be part of the solution is telehealth, and we have been supporting the adoption of telehealth for the better part of 15 years. For those with reliable transportation, with available healthcare providers nearby, with stable childcare, and with employers that allow for absences from work without fear of losing wages, telehealth is a wonderful convenience. For those whose lives are more complicated, including most Medi-Cal enrollees, telehealth is so much more. It can be a lifeline to timely care for them, their children, and their elderly parents. For this reason, when COVID-19 forced many providers to limit access to in-person care, our board of directors swiftly responded with a $6.5 million investment in what we call a tipping point for telehealth. And in many ways, these past 18 months have been just that. In addition to actions taken by health centers, as we'll discuss today, policymakers around the country quickly approved coverage and payment policies to support telehealth, and at the federal and state level, some of these changes are being made permanent. Safety net patients, many of whom experience telehealth for the first time, overwhelmingly report positive experiences and the desire to continue to have the option for phone and video appointments when appropriate. But our work is far from done. Without a concerted effort by policymakers, health plans, and safety net providers, we risk sliding back and losing the gains we've made. Even worse, we risk not only a golden opportunity to reduce the gap in access to care between Medi-Cal enrollees and those who are privately insured, we risk widening this gap. Which is why I'm delighted that today we have an opportunity to reflect on the past 18 months, to learn from our experiences, and to hear from healthcare leaders who are paving the way to a brighter future for their patients. Next slide, Natasha. We'll begin with a presentation by Natasha Aurora of key findings from the midpoint of the Connected Care Accelerator, the cornerstone of our tipping point for telehealth. Next, we have a discussion panel with safety net leaders facilitated by my colleague, Diana Camacho. This will be followed by audience Q&A. Please add your questions at any time using the Q&A feature. And before closing, we also want to share some great new resources developed by our partners at the Center for Care Innovation that we're excited about and think others will find useful. As some of you know, the Center for Care Innovations co-developed and ran the Learning Collaborative. After the webinar ends, an evaluation will pop up. Please do complete it. It's an opportunity for us to hear what you liked about this webinar, to identify topics for improvement, and to solicit your ideas for future topics. Next slide. For those who don't already know about the California Healthcare Foundation, this is a brief overview. We are led by Dr. Sandra Hernandez. And if you're interested in learning more, please visit www.chcf.org, where you can find more information about our 3 goals and strategy under About Us. Next slide. As I noted earlier, the cornerstone of our investment in telehealth this year and last was the Connected Care Accelerator. All 43 health centers selected to participate received flexible grant funding to expand their capacity to deliver care through telehealth and were required to periodically track and report on utilization. 23 of these health centers also participated in an intensive learning collaborative for the past year, intended to identify and address challenges to building virtual teams and engaging patients, to test various approaches so that collectively we would better understand the infrastructure, data, staff, and skills needed to operate telehealth at a high level, and to document and share best practices. I also want to thank LA Care and the Blue Shield of California Foundation for contributing resources to this program. As we often do, next slide, please. As we often do, we paired our learning collaborative with an evaluation to support real-time learning about participants' experiences, to support timely dissemination of findings so that others could benefit from our lessons, and to understand which elements of the Connected Care Accelerator worked well and which could be improved. Today's webinar focuses on midpoint findings. In early 2022, the final program evaluation will provide 6 additional months of data, additional qualitative data, and the results of a provider and staff survey. Also, the Connected Care Accelerator is one of only a few resources with reliable information distinguishing between phone and video use, so we are continuing data collection for another year. I'm pleased now to hand the baton to two superstar colleagues. Next slide, please. Starting with Natasha Aurora, who will share the evaluation results. Natasha is an evaluation and learning associate at the Center for Community Health and Evaluation, where she has been a partner with us on every step of this journey, helping us and health center participants learn from this rich experience. Following Natasha, Diana Camacho, my CHCF colleague, who is now leading our efforts to expand access to care for Medi-Cal enrollees through telehealth, will moderate a distinguished panel of healthcare leaders. Before joining CHCF a few months ago, Diana developed and led several initiatives in the safety net at Kaiser Permanente, including the design and launch of a national telehealth initiative. I couldn't be more excited to have Diana as a colleague and to have her bring CHCF's work on telehealth to new heights. Natasha, the baton is yours.
Thank you, Chris. I will start by giving you all an introduction to the data that feeds into the findings I'll be sharing shortly. So there were 23 health centers participating in the Connected Care Accelerator Innovation Learning Collaborative, and each of them generously shared with us clinical utilization data from February 2019 to February 2021, including the number of visits and unique patients by modality. So that would be clinic, phone, and video that were conducted monthly. And then we conducted 2 interviews with each of the health center teams at the beginning of the initiative in October, November 2020, as well as halfway through the initiative in March and April 2021. And health centers have also been sharing some project materials and artifacts that were created throughout the collaborative that we reviewed as we were putting together these findings. Based on all of that, we reached 4 key findings at midpoint of this evaluation. The first 2 really center on the utilization data, and the second 2 really center on what we learned from speaking with health centers and reviewing their progress through the materials they shared with us. So number 1 is that telehealth replaced a large volume of care during the pandemic, with most of these telehealth visits conducted by telephone. Number 2 is that the rate of adoption of video visits specifically varied across the health centers and was supported by a few key implementation practices that we'll talk about. Number 3 is that each health center needed to develop a unique telehealth model based on their patients' needs, their staffing models, and the technology and infrastructure available to them. And number 4 is that health centers implemented and continue to seek solutions to address the digital barriers often experienced by their patients. So we'll start by taking a look at the utilization data by phone and video in these first 2 findings. I know there are a lot of questions about the utility of phone versus video and when it's appropriate to use each. I will leave that for the panel later and focus on the utilization data and what we can understand from it. So telehealth replaced a huge volume of in-person care in the safety net throughout the pandemic, and most of these visits were conducted by telephone. If we look back to the baseline data that we collected from before the pandemic, we can see that the percentage of all visits that were conducted by telehealth was really small. It was less than 4%. During the pandemic itself, for the data that we have up to February 2021, 53 to 75% of visits each month across the whole collaborative were conducted by telehealth, and that includes both telephone and video. Of all of those visits that were conducted by telehealth in both modalities, the vast majority were conducted by telephone. In primary care, that was 94%, and in behavioral health, that was 89%. So we can take a closer look at some of this data in this figure here. This shows us the number of primary care visits completed each month across the entire cohort. This graph goes from December 2019 to February 2021. The blue visits are in-person clinic visits. The orange visits are telephone visits, and the red bar here is video visits. So one of the key things to notice here is that there is not a decrease in volume. Volume maintained itself pretty stable throughout this period of time. and patients were still able to access care. And the vast majority of that care, where you see this blue line here drop off, is in the orange phone visits, with a little slice in red of video visits at the top. For behavioral health, things look pretty similar, but there are a couple of key differences to notice. One is that if you look at the beginning of the pandemic around March, April 2020, you see that the volume in total actually increases. So we've heard anecdotally from health centers, although we didn't collect this data specifically, that there were some decreases in no-show rates that allowed for this increase in volume and access to behavioral health care, which was really important during this time. Another difference here is that the red bar, or the video visits, is a little bit wider. So there was a little bit more utilization of video in behavioral health compared to primary care. What we learned about video visits specifically is that the rate of adoption and spread of these visits across the health centers really varied. So we saw that in primary care, this was 6% of telehealth visits across the entire cohort, but that number looked really different at different health centers, which we'll take a look at shortly. In order to implement video visits at all, there were a few key things that each health center needed to do. The first was identifying and adopting a video visit platform. The second was creating workflows for their care teams in order to implement video visits. They also needed to onboard patients to the use of the platform, which I'll talk a little bit more about later. In some cases, health centers needed to establish new care team models. This could include things like having MAs that were specifically designated to provide telehealth support, or introducing new roles like that of a digital coordinator or navigator. And finally, health centers also needed to determine how to connect interpreters to video visits, which varied in ease across different platforms. We found that there were a few key practices used by health centers that had overall higher rates of video utilization. One was using a platform that provided easy access for patients, such as one that just allowed the patient to receive a link that they clicked on, as opposed to needing to log in or download an app. Another was scheduling telehealth appointments as video appointments by default, rather than leaving it up to patients or providers. A third was setting targets for video utilization, which could be targets of percentage of video visits out of all telehealth visits to complete, or could have been quotas on the number of phone visits that they didn't want to exceed. And a final was prioritizing all the operational bandwidth needed to make this transition. As you can see, there's a lot of pieces involved in implementing video visits specifically. So given all of that, we saw a lot of variation in health centers' capacity to implement these video visits. What this graph shows you is the percentage of primary care telehealth visits that were conducted using video at the 25th percentile, 50th percentile, and 75th percentile of the entire cohort. So the health centers at the middle of the pack were conducting about 6% of their primary care telehealth visits by video in February. The health centers that were newer to implementing video visits were conducting 0%, but that's a rounded 0%. So they were often still conducting a handful of visits by video. So they might have been at the stage of piloting with a few providers or trying out some new technology. Whereas the health centers that were using some of the key practices that I just talked about were conducting about 29% or more of their visits by video. So we really do see a huge amount of variation based on the resources that health centers were able to put into this, as well as the technology they were using in other aspects of their care model. So there's a few key pieces that each health center needed to figure out in order to create a telehealth model of care. Some of that, we'll hear a lot about each of these in the panel shortly, but just to touch on an introduction, some of this related to staffing, needing to figure out new care team roles, as well as to deal with some of the staffing shortages that came up during the pandemic. Some of this related to technology. Health centers needed to make either long-term decisions about what technology to adopt and really think about their needs of the patients as well as the back-end needs of their health centers. Whereas other health centers took a more short-term approach and decided to adopt what was quick and doable in a short period of time. And some of those health centers are revisiting choices and figuring out what would be more sustainable for them. There were also some platform-specific facilitators and challenges. Like I talked about before, some video platforms were more accessible to patients than others, and platforms also have different back-end features such as EHR integration. Health centers also needed to determine the criteria for when to use different modalities, whether that was video or phone. In some cases, that involved figuring out clinical criteria. In other cases, provider and patient preference were taken into account. And like I talked about before, some health centers instituted quotas or targets for their use of different modalities. Another big piece of figuring out the model of care provided at each health center was looking at the financial incentives and reimbursement policies. Overall, the current policies in place around reimbursement really served as a catalyst for rapid change. Health centers knew they could get paid for using telehealth and needed to get paid, and so were able to use both phone and video visits. In some cases, health plans offered incentives for the use of a particular percentage of video visits with their patients. And so health centers that wanted to take advantage of those incentives really moved towards implementing more video visits. Another finding was the importance of addressing patient needs and specifically digital barriers to being able to access visits. And this really played into the video visits specifically. I want to note that one thing that we heard from health center teams was really about the strength of their patients and the support provided to patients from family members and across generations in order to try new things and use technology that they weren't always comfortable with. From the panel, we'll hear about some strategies for building patient capacity to engage in telehealth visits. This is where a lot of health centers got really creative and put videos online or had their health education teams pivot to providing some technical support to patients, as well as tried a whole host of strategies. Some other important parts to addressing digital barriers included enabling the use of language interpretation, specifically in video visits, implementing remote patient monitoring in some cases, enrolling patients in patient portals when that was important for them to be able to access video visits on certain platforms, offering hybrid visits, which included an in-person component along with the ability to connect with the provider who may have been in another location, and providing access to hardware or Wi-Fi when needed, including setting up Wi-Fi in parking lots in some cases. So in order to hear more about this, I will pass the mic on to Diana and the panel.
Thank you very much, Natasha. I'm really pleased to switch gears a little bit and introduce our panel. I'll be moderating a panel of 3 leaders whose organizations participated in the Innovation Learning Collaborative, whose evaluation results Natasha just highlighted. We'll be discussing specifics of their telehealth practice and their views of telehealth going to the future. So let me start by introducing our panel. I'll start with Dr. Delphine Thuot, who is an associate professor in residence at the University of California, San Francisco. She's also associate chief medical officer for the specialty care and diagnostics at Zuckerberg San Francisco General Hospital, which many of you know as our public health system in San Francisco. I'd also like to introduce Dr. Jason Cunningham, who is the CEO at West County Health Centers, an FQHC with 6 locations in rural Sonoma County. And last but not least, Dr. Rakesh Patel, who is the CEO of Neighborhood Healthcare, an FQHC serving over 75,000 patients in San Diego and Riverside Canyon. Thank you, all 3 of you, for joining us. So I'd like to start our conversation with talking a little bit more about your experience with telehealth via video, given that was one of the main highlights that Natasha talked about. Given the key finding that most health centers were doing virtually no video visits before the pandemic, and when the pandemic hit, phone overwhelmingly became the primary mode of delivering telehealth, and still is today, because of the ease of implementation and accessibility. Video, on the other hand, presented many other challenges such that Natasha already highlighted to implementation, and we therefore saw wide variation in video usage rates across health centers. So I want to start with Dr. Cunningham, who I know his organization has grown the use of video telehealth significantly. So Dr. Cunningham, can you tell us what were the most important steps your organization took to increase the use of video?
Thanks, Diana. In our organization, we are definitely bought into the concept that video is part of what we needed to pivot to. We think we were excited about it prior to the pandemic, but during the pandemic, it certainly showed us that we needed to have that modality for us to be successful. And I think it's probably the future. I think relationship-based care, being able to be where patients are at, being able to coordinate care across was important. One of the most important things that we had was actually participating in something like this. I think the California Healthcare Foundation and CCI really allowed us to practice in a safe space, to be able to learn from each other and pivot quickly. But just to show a little bit of, I think a picture is worth 1,000 words and a map is worth 1,000 pictures. So I'll show you a map. To show you that we are a rural health center. This is our catchment area. We serve patients who are primarily in rural West Sonoma County. This is our area here. This is the dots represent patients in our electronic health record. And the pink and the yellow is the FCC broadband deployment. So just to let you know that we live in an area that's very rural and for patients who have poor connectivity. So when I show you the next slide, which really gives you a sense of our commitment and what we ended up doing with our video, we started back here in March. If you look at the blue is the percentage of telehealth that's by phone, and the yellow is percent by video. And we kind of came along here somewhere around 15 or 20% for some time. And that was when we were using our electronic health records version of our video. And we decided that didn't work. It wasn't very successful. It really had to do with the easeability of the patients getting access. Our providers were frustrated. It wasn't working, even though we had a very engaged leadership team. And so we switched to Zoom, and we switched to a Zoom model in which was kind of off the shelf. We use breakout rooms, and I'll show you a quick slide of that as our way for us to have an experience that was similar to our in-person experience. So we had breakout rooms for every exam room. We had team rooms where patients were doing, and that worked. The staff felt like that worked. Our patients felt like that worked. And that sits somewhere around November, December, where we ended up around 30% of our visits were video. And it wasn't until we made a commitment as a leadership team that the default was going to be video that we jumped. My thing was circling. So it went from about 30% to 50%. And that was our goal, that we would decide that instead of the patient and the provider deciding that was the whatever they wanted was phone, which was easy. They know how to do that. We said the default needed to be video unless you didn't have any connectivity, somebody else in your family was using the only source of connectivity, or you had some sort of clinical reason you couldn't do that. And we saw it jumped around 50% soon after that. And then lastly, just to show you the Zoom experience, because I think people don't really get what we're talking about. We made the whole Zoom clinic, all of the staff became co-hosts. And so we were all able to jump between breakout rooms. And so we had the waiting room, which was just if you come into a Zoom room, you're waiting for somebody to let you in. That person was the concierge, and exam room 1, 2, 3, 4, 5, 6, all the way up to 12 are breakout rooms. And then we had breakout rooms called care team room and a breakout room for an actual breakout room. And a patient would enter into the exam room, the concierge, and say hello to the concierge person, who would then put them into a breakout room exam 1. And then the provider or the medical assistant would jump into their exam room, just as if you were going between breakout rooms, and come back out. The provider would go in and out. They became very much similar to an experience that we would have in primary care. And that made all the difference for us because it was similar to what we did before. We had a serious amount of collaboration that was actually better than our regular in-person oftentimes, and the patients felt held, something they were considering. So I'll stop there. I think innovation tends to be something that you can iterate on, something that's existing, and that made a big difference having support of of something like a collaborative, and then choosing a strategic decision to say this is our default made the biggest difference for us.
Great. Thank you, Dr. Cunningham. I think really impressive to see the strides you've all made on the video front. I want to shift the conversation slightly on video, and I think many of you all know a key policy discussion happening right now is around the value of audio-only telehealth, specifically how it should be paid for. There seems to be a tug and pull between audio as more accessible to more people than video, and video being potentially of higher quality, which I think we all have some questions about. So my question is, what is your take on how to balance the accessibility of audio visits and the perceived quality of video? And is that even the right question to be asking? And maybe I'll start with Dr. Patel.
Thanks, Diana. So, first of all, I just want to start off by saying I am so happy that we're actually having this policy discussion. Sadly, it's taken a pandemic for us to get to this place, but we got to look for silver linings, and this is really one of those. This pandemic has demonstrated the critical need to have virtual visits as part of the toolbox in taking care of patients, especially our patients who struggle to make it out of their homes at times because of crippling mental health illnesses or transportation issues. So as to the question of quality differences between audio and video and payment parity, I begin with what are our goals? As patients, we want access to our providers with the least amount of friction. We want to be listened to and we want our questions answered. Depending on what we are dealing with, this can be addressed in one of three ways: in person, audio, or video. And I would argue that each of these modalities provides high quality care when utilized appropriately. As for audio, follow-up on diabetes, blood pressure visits after a medication adjustment, that doesn't require video. It does require some data from the patients, which providers can get through glucometers and blood pressure machines, and they can make those adjustments via audio. A lot of chronic disease management, much of what we do can be effectively done over audio visits. Many acute care issues can also be handled via telephone as well. I think that as Natasha's slide demonstrated, in behavioral health, we actually saw this huge uptake. Our experience at Neighborhood before the pandemic was a 30% no-show rate. That is now less than 10% for us. When we remove the barrier of transportation, that has been critical for getting our patients more services that they otherwise weren't getting before. As for video, when it works, it has a lot of benefits, as Jason just talked about. It allows you to have that intimacy, to take a look at rashes and facial expressions, just check in on a patient's personal hygiene. The challenge is that video is still challenging on both ends. For many of us, we struggle with Zoom videos, our cell phone coverage. For our patients, that's even a greater challenge, and it's magnified. These are challenges, but as we've talked about, we need to overcome those challenges because that modality is equally important to fill in the gaps between audio and in person. To be honest, at the end of the day, I'm a family doc, that I'm still a bit old school, and I prefer to see my patients in the exam room one day without masks. Hopefully that time comes soon. Well, child exams, discussing a challenging diagnosis, cancer screening, those do belong in the office. That being said, I've come to recognize the utility of each of these visit modalities and help us achieve those goals I mentioned. Having access, being listened to, and having our questions answered is what we all want as patients. Our patients finally have options that many of us have had for quite some time. To achieve health equity, we have to find ways to reduce barriers. Audio visits definitely help, as does video. Patients ultimately will drive which modality will serve their needs when given the opportunity to decide. Thanks.
Thank you, Dr. Patel. Dr. Tuo, anything you would add?
Yeah, thank you. I would just echo that this is really about access. I think at this point in time, we don't have a lot of data to drive whether a video visit is better than an audio visit and where that lies within the in-person video or within the in-person visit. So I think we are also just trying to meet the patients where they are and understand where the provider and the patient needs are and just try to maximize access to the best of our ability.
Great. Thank you, Dr. Tuo. And speaking of patient needs, I think I want to shift a little bit to talking about patient barriers, which many of you have remarked on already. I think we all agree that telehealth has the potential to reduce disparities that Chris had mentioned and we're seeing across in some of the data by removing these barriers to care, like transportation, having to take time off of work. But like I said, we're also seeing data indicating that some patients are having difficulty accessing telehealth. Including patients whose preferred language prefer to receive their healthcare in a language other than English, and some low-income patients. So each of your organizations, as part of the Innovation Learning Collaborative, took on really innovative strategies to address these barriers. So I'd love if you could highlight one patient barrier your organization observed and what you did to begin to address it. And maybe we'll work our way back around to Dr. Cunningham, if you'll start, please.
I think before this pandemic, we asked patients to drive to our health center, sometimes an hour and a half away, to wait in my office for an hour, sometimes to see me for 15 minutes to drive back. And I think this basically said, as Prakash said, it's changed that paradigm. So I think the reality is we should be going out to where the patients are at. And particularly when you have connectivity, that equity lens, figuring out what the patient needs. Excuse me. And so what we've done is particularly in our rural areas, we've provided access points in those rural areas. So partnering with libraries or police or fire stations and putting endpoints there, being able to allow patients to drive to our health center and sit in the parking lot with an iPad, areas figuring out the connectivity for our patients. And I think that offers a new opportunity, not just let's just figure out what we need to do to the pandemic, but what does it look like for collaboration? How do we bring in other partners like CBOs? How do we figure out school-based systems that aren't big health systems in there? I think we can think about this as an opportunity if we think about taking the healthcare away from the building and move it out to where the people are at, which is interesting.
Great. Thank you, Dr. Cunningham. Dr. Patel?
Yeah, similar to what Jason said, one of those barriers was addressing those patients who didn't have access to video. And so early on in the pandemic for us, we used a risk calculator to decide which patients should come in for visits versus those who should not come in. And so as you would expect, those with chronic diseases and elderly, we said stay in the home. The challenge was this pandemic dragged on and continues. And so we were starting to lack the knowledge or the data that we need to take care of these diabetic patients, specifically A1Cs. And so what we ended up doing through grants through HRSA, as well as some community grants, we got 3 Toyota RAV4s, part of our mobile outreach team. We put lab equipment in each of these RAV4s, and they were staffed with a medical assistant and went out to the patients' homes to collect lab draws, as well as be able to provide video visits at the same time. So we use Microsoft Teams. And so our medical assistants would do a visit in the in the patient's home, connect with the provider in our office, and would be able to manage the patients that way. I was lucky to do a couple of these visits where we actually got some lab work done, sent the lab, got the results, sent the van out 3 weeks later, was able to go over the results and tell the patient she had anemia while she was in her ranch in a rural area. So it's been vital for us to not only collect labs, but to provide visits. We're also now letting providers select patients that they feel would benefit from having someone get a video visit, especially around our behavioral health patients.
Great. Thank you, Dr. Patel. And Dr. Tua, do you want to share something that your system did?
Sure, yeah, thank you. I think one of the other, similar to what has been said before, many of our patients have barriers to using video. The digital literacy is quite low, limited English proficiency as well. And what we identified is that this would try to onboard patients onto a platform, whether it's the patient portal or the video platform, requires a fair amount of time and requires expertise in that platform as well. And we found that our medical assistant staff or clinical staff just didn't have the bandwidth nor the time to do that, particularly during the COVID pandemic when we were all activated to deal with the COVID within the city of San Francisco. And so we created a new role, a telehealth ambassador, which really meets the patient where they're at, tries to help them get onto the patient portal, get onto the video platform so they can use that for upcoming provider visits and hopefully help increase their digital literacy for anything that they do. We are mainly relying on volunteers and medical students. This actually has proven to be a great opportunity for early medical students to have direct patient contact, and it's been actually a great experience. So we hope to keep building that as we move forward.
Great. Thank you, Dr. Tuo. Excited to see taking advantage of the full workforce in these efforts. So kind of shifting to what comes next, I want to talk a little bit more about the future of telehealth. And I think we've talked about the access issues as well as the opportunity that telehealth presents. But I'd really like to hear about your vision for telehealth. Specifically, how will telehealth be a part of your organization's care model going into the future? Thinking most immediately when we're still in this pandemic world, unfortunately, and into the long term. And what opportunities and challenges do you foresee with making this vision happen? And we'll circle back around and start with Dr. Cunningham again.
I just have to say I love the RAV4 idea, by the way. I do think, in my mind, all of healthcare is relational, and particularly in primary care, and that's relationship between the team members, that's relationship obviously with the patient, but that's also relationship with other providers, other systems. When we start getting upstream, we're talking about collaboration with community-based organizations, with pastors, with faith-based, with other systems. And I think telehealth allows the barrier of the place where somebody has to come into the office to be taken away. And I really am interested in that. So what does it really look like to collaborate? What does it really look like to have a dialogue? What does it really look like to have the patients bring in their care team where that member is important? And I think in my mind, we have to get away from the technology being the problem. So as Althina was talking about, what do we do to make sure our patients are equipped for that? But then our system needs to not have that problem. So in my mind, we need to be able to be nimble and then meet the need as we're going through these different phases of this healthcare transition. Alternative payment models, figuring out how to look in systems of care rather than individuals requires us to be able to have collaboration. So I think whether that's video or phone, there is a need for us to get outside of that single episodic visit and start turning into a collaborative where the patient or the person is with others. And I think that's the future of healthcare, or telehealth.
Great. Thank you, Dr. Cunningham. Dr. Patel?
Yeah, telehealth has to remain a part of our care model. It's been a game changer for really, as we've discussed here today. We see this, as part of the solution to provide more comprehensive care to our patients. We do a lot of episodic care. We see our patients and we don't have touches in between because it's really hard for them to come back in. And so one of the areas that we've started to talk about is remote patient monitoring. How do we start to collect some of that data in between visits, vital signs, blood sugar readings, and pulse oxes? We are just about to launch our program. We are going to have a pilot of 500 patients to start with, and these will be some of our diabetic patients where we've got some connected devices that we will deploy that will also allow us to do video visits with them. The challenge right now is RPM is not reimbursable for FQHCs currently. And really, I think to solve some of these funding issues of RPM and telehealth, we have to continue to work towards APM, alternative payment models. Many of us believe if had we been in APM during COVID, we would have spent less time worrying about our finances and more time on better understanding how to better deliver care for our patients. I'm really excited that telehealth is here through 2022 and that we're getting to work with the state to figure out how to make this work for the long term. The details of APM are complex. I've been privy to some of that, but we do need to figure it out. Workforce challenges are only getting worse. Patients are wanting care beyond just coming into our office. And ultimately, we need to better utilize resources so that we're doing the right care at the right place at the right time.
Great. Thank you, Dr. Patel. And Dr. Tuo, if you had a crystal ball, what would it tell you about telehealth?
No, I'm just going to piggyback off of what's been said. There's no doubt that telehealth will remain a part of our healthcare delivery, and I think will continue to be an important part. I think we need to think about telehealth broadly. We're focusing on video visits today, but as has already been documented or discussed, sort of home test, remote home monitoring, point of care diagnostic testing. I think store and forward with images has already really revolutionized a lot of the way that we provide some care, and will continue to do that. And so I think just broadly thinking, how do we invest in our infrastructure to continue to allow that moving forward? The pandemic has provided a silver lining in that sense, right? We've been forced to invest in the infrastructure and better figure out how do we integrate these systems and these platforms, all of which may be quite varied, into our single care delivery model to better service our patients. It's here to stay. And so we need to get with the times.
Amen. Okay, well, we're going to shift to Q&A. I see we have some wonderful questions coming in. So I want to actually invite Natasha to join us back on screen because I'm seeing some wonderful questions about data. So to kick us off, Natasha, the first question that I was seeing was, who are the participants of the clinics, of the evaluation findings you highlighted, and how are those clinics selected to be involved? And coming from the Healthcare Foundation, I can start by kicking that off, and then I'll hand it to Natasha to talk more about a little bit more about the data that she shared. But as Chris mentioned early on, there were 23 health centers that participated in what we called the Innovation Learning Collaborative, and those clinics applied for a grant through the California Healthcare Foundation, and they received resources to focus on telehealth. And they represent a wide geographic scope of health centers and health systems, such as, neighborhood and West County and San Francisco. So lots of different types of organizations were involved in that. So Natasha, a question that I see for you is where were these virtual visits conducted for new consults or follow-up visits, or under circumstances?
We don't have exact data on that. We collected an aggregate number of visits that were conducted monthly in each modality, and we didn't segment that by new patients versus patients that had previously been seen. We did collect data overall on number of new patients that were seen monthly at each health center, and that number did not seem to go down much at the beginning of the pandemic when telehealth was initiated. Some of the further details on that will be looked at the endpoint analysis.
Great. Thank you, Natasha. And a follow-up question for you around which EHRs were used by any given health center, including level of integration and the use of video. Did you see any correlation between the use of video and the EHR used, or maybe even the video platform used?
Yeah, this is again something that we'd like to look at endpoint, whether there is some correlation between amount of video that's used and some of the technology pieces, but we don't have that information right now. What we do know is that health centers that had platforms that were relatively accessible often used a higher rate of video, but that doesn't necessarily correlate to whether that was integrated in EHR or not.
Do the panelists have any comments about that? Some of the technical issues that you came across related to EHR integration and the Zoom platform, the video platform that you used? I know, Jason, you mentioned Zoom. Do you want to comment on that? Dr. Cunningham, your experience with integration and choosing Zoom platform?
Yeah, I think just like anything else, you have to iterate. I think if it's not working, you pivot, you make sure you have quick feedback. So I think a lot of platforms can work. I wouldn't want to say that some platform is the way to go. For us, I couldn't make a leadership decision unless I had a technical solution, though. That was a really important difference for us. So I couldn't say, this is our future. We have to make sure that we have an equitable offering for whatever the patient needs. If the providers were not able to get on, the patients were not able to get on, it didn't work. And that was actually our story. So all I would say is there's probably going to be many, and I don't want to be married to one. I want to be able to work over time, but it's got to work. Otherwise, leadership doesn't matter.
Great.
Go ahead.
Go ahead. I would just add that we're actually on two. So we're using Zoom and Doxy.me, and it's really come down to primary care versus behavioral health. So for whatever reason, that's just how it's kind of fallen out.
Yeah, I think we are in the midst of trying to do an integration actually within our EHR, because we have found that our providers were having a harder time with a separate video platform. And so right now we are doing it. We have a separate video platform that's not integrated, but based on the feedback from our clinicians, we are moving in that direction. And so we hope that will certainly increase our use.
Thank you, Dr. Tuo. So a question that we're getting is around more around video visits. So I think the person who asked the question makes the point that other cultures are more open to technology than others, and patients like to have face-to-face appointments, like you mentioned, Dr. Patel. So how are you all working to overcome these barriers and address the desire for face-to-face visits from your patients and offer them telehealth? And maybe I'll start with Dr. Cunningham, given you guys have done a lot on the video front.
Ultimately, I feel like we've got to a place where we've got a little bit of what the patient wants and what our system offers is that kind of 50%. I think we could probably get to 60% if we were talking about telehealth alone. But to Rakesh's point, I think there's a lot of value for in-person, obviously, that relational care, being able to have a physical exam. And there's something about community that when we're in community together, in my mind, it's rural for us. Connectivity was a big issue. Being able to have a platform that was easy, digitally translated correctly for different populations. We spent a lot of time making sure there's an equitable offering of those systems, but that's what we do in FQHCs. So I think the reality is we'll probably settle into a place where ultimately it's about what the patient needs or what the patient wants or what the situation offers, and then the technology will allow it.
Great, thank you. And Dr. Tuo, I know you all you have done a lot to understand your patient preferences and such. Is there anything you would add?
Yeah, I would add that relationship with the whoever the provider is, whether it's a primary care provider, behavioral health specialist, or specialty provider, I think also plays a role. So we have found that patients have been much more willing to do video or audio when they know their provider well, and they understand that the provider recommends that that might be the best option for that next visit. When a patient doesn't know their provider as well, we have found here that they've been a little more hesitant and have preferred to come in person. So we'll have to see over time how that follows.
Great, thank you. So I know there were some acronyms thrown out throughout this panel around APM, RPM, all the PMs, if you will. So maybe I'll ask one of our esteemed FQHC partners to explain to the group what APM is and and connect it specifically to telehealth. Maybe Dr. Patel, I think you mentioned APM, so if you could explain that a little bit further.
I'll do my best. So, currently we're paid basically in a fee-for-service model. So meaning that when we see a patient, we're paid a reimbursement. In an alternate payment model, you're really being paid more for a total population of care. And so it allows you to provide services in different ways other than what we call billable providers. So in our current system, we only get paid if a doctor, a nurse practitioner, physician assistant, psychologist, a licensed individual sees those patients. And before the pandemic, it was within the four walls. In an alternate payment model, we can now do other unique, innovative sort of ways of providing care. So we can send a nurse into the field as part of the care continuum, and we don't have to do each of these visits for a reimbursement because we're getting paid for the population of care, being held to quality metrics and access metrics as well. So it's just a different way of funding, really almost like a prepayment funding to provide care and making sure you achieve certain quality and access metrics. Hopefully that's clear enough.
APM is a confusing topic, but I think you summarized it well. Thank you, Dr. Patel. So one other question that I am seeing in the chat is a kind of more of a visionary question on the opportunities for telehealth to expand access to providers outside of our state. So if virtual visits are so effective, do you see a future stage where doctors from international locations will be providing services to California patients? If so, why not? I mean, yeah, Dr. Cunningham, it looks like you're ready to chime in.
I lived in Copenhagen for a year. I have a provider in Panama. I have a provider in New York. I think it allows us to be able to have a nimble workforce to be able to offer that. And I think on the flip side, patients have access to providers elsewhere, and we'll have to figure that out. I will say, just to add to what Rakesh was saying, payment matters. So when we're talking about advocacy, and those are on the panel or in the attendees, it drives. We have perverse incentives to be able to have a physician see it when really they need an educator, or I need to be in the home or with somebody by telehealth in their grocery store or something like that. So really advocating for us to be able to be paid in this comprehensive way so that video, where the provider is, where they live, and where the patient is, can be just being whatever is necessary and what's appropriate.
Great. Thank you for adding that point about APM. A question I'm seeing is, if telehealth enables greater access to providers, do you envision that will help or exacerbate workforce shortage issues? And whoever wants to start.
Well, I think that's why I bring up alternate payment models as part of that. I think it's part of this continuum. I think in the short term, I don't know if it's going to worsen it. I think it's just, we have to be careful. We're not, adding more visits. We're actually doing visits in different ways. And so, yes, we have lower no-show rates, but we're not all of a sudden making our providers see X number of more patients than they were already expected to see. They're just seeing them in a different sort of modality.
And I'll just add to that and say this is why it's also important to not just focus on physician or clinician virtual visits, but also to work on really implementing nurse-related visits, virtual visits, medical assistant virtual visits, behavioral health virtual visits, because all members of the care team are really essential, and we really rely on all members of the care team to provide high-quality healthcare. And so everybody needs to be able to operate in this virtual system to be able to deliver the healthcare we need.
Thank you. And thinking about the broader needs of our patients that we're serving through telehealth, how are providers addressing screening or possible interventions for things such as abuse, domestic violence via telehealth in your organizations? Someone want to start?
I might just add to put an exclamation on a lot of what we see are these issues that don't fit into a 20-minute visit, and they don't show up really well in our office. So we're actually in our patients' homes now virtually. And to the point where we can actually extend to community members, community partners, where patients are at. I think we will have a different view of what's really happening in our patient space, which is really where behavior change happens, where we can get more support and and then again, healthcare isn't the provider of choice when we're talking about upstream work. So how can we partner with others? And I think telehealth it does offer a better way for us to collaborate. So I think as healthcare gets more upstream to work on the issues that really matter, and again, I'm a physician, I don't want to say this too loud, we matter less, we're more diagnosticians and more collaborative, then telehealth offers us a space to be able to be collaborative in that way.
I think that's a good point. I have another question that kind of builds off of that. And can you all talk to the unique facilitators and barriers for telehealth with people with serious mental health, serious mental illness and substance abuse disorder across your populations, and how you're using telehealth? Because we talk about it in the behavioral health setting a lot, but specific to that population with more serious needs. Delphine?
Yeah, I can speak a little bit to this. Our homeless outreach team, or our homeless teams, or street medicine teams, I've been amazed at the ability to get them connected to us at the hospital using video and using audio telehealth. These are individuals who we wouldn't be able to access our care otherwise. And so I think we've made great strides for that population in particular. My hope is now that we have some sort of a connection, we can continue that moving forward, whether that is still only via virtual modalities or also having them come in so we can see them at least once in person, but at least giving them access to some of the care that they need. It's been great.
Great. Thank you, Dr. Joe.
I would build on what Jason said about that community. So with our more moderate to severely mentally impaired patients, we've been able to talk with their families at the time of those virtual visits and get more information that historically we couldn't have gotten before. Many of them were lost to follow-up because they just were too dysfunctional to even come into the practice, or they had a lot of anxiety in the waiting rooms. So we've seen a lot of those barriers kind of peel away, as well as through virtual care.
Great. I think you all have touched on several questions around homelessness and such, but Dr. Cunningham, anything you would add?
I just want to keep pushing us. I've heard some great models of people with medication-assisted treatment for opiate use disorder, where you've got an endpoint under a bridge, for instance. It's sometimes like even a couple hours makes the difference between wanting to get care and needing to get that next hit, if you will. So I think if we can push this to say, getting out in the field, putting endpoints where people are at, it should transform some of those really complex needs that our patients struggle with.
Great. So I think our last question, I'm going to make it a twofer. So the question is at first about the data, Natasha, that we saw. Is telehealth data broken out by patient age at all? And were there any findings specific to patients' age and their use of telehealth, particularly video visits?
We do have some data segmented by age, and what we are seeing is that pediatric patients are higher utilizers of video visits. And what we've heard from clinicians is that it's really helpful in those cases to have a visual of the patient, and also that the younger population, younger parents are often familiar with technology. We have not seen lower utilization of video among patients who are 65 or older, so we are seeing them use video at the same rate as other adults.
Interesting. And maybe a question for our panelists. For that, the 65 age plus or older adults, have you provided any supports in particular to support that population with their telehealth access?
For us, I don't know, I don't think it's the ambassador title that Delphine had for theirs, but we do have specialized MAs who are, versed in motivational interviewing and care coordination, and kind of do some pre-screening calls with our patients who we think may have some challenges to try to address some of those beforehand.
Yeah, and I think just trying to leverage those patients' family members or community members to help them log on to whatever platform available, just really trying to leverage their community to help bridge those gaps.
Great. We are just out of time for our panel, so I want to thank our panelists very much for your thoughtful responses and for your leadership in the telehealth space. So thank you to all you all. And then I'm going to introduce our final speaker, Sophie Bergquist, the president for the Center for Care Innovations, who's the organization that ran the Innovation Learning Collaborative you just learned about. So Sophie's going to be sharing some resources on telehealth for you all to use. Take it away, Sophie.
So we at Center for Care Innovations were honored to coordinate the Connected Care Accelerator. Such amazing work done across all the teams, and you've heard about that today. The 23 organizations that did participate tested many ideas and developed different solutions that they shared with us and shared with each other. And we want to make sure that these resources are available to all of you and to support organizations that are working to advance their virtual care services. So we've structured these very rich resources as a patient journey map. So you will be able to see what resources are most relevant for what stage of a patient's journey. And this includes, for example, scripts that organizations use to understand patients' ability and comfort to join a video consultation, and based on that, plan for and prepare for the support that may be needed. And there are many different workflows to increase the use of video, workflows for remote patient monitoring, and several other things that you have heard about today. You will also find examples of patient education videos and materials. And we are now in September finalizing this journey map with resources, and we'll make it accessible on the Virtual Care Learning Hub. You can already find many resources there, and I'm putting the link in the chat right now. So you can go there, and I would encourage everyone to go there, look at the resources, share them with people who may benefit, and come back towards the end of September when you will get access to this journey map that I just described. I would also encourage all of you to sign up for CCI's newsletter at the very bottom of our webpage, because you will through that also get updates when new resources are made available. And with that, back to you, Diana.
Thank you very much, Sophie. So I'd like to welcome all the presenters back on screen so that I can give you a profound thank you to our panelists and presenters for your thoughtful participation, and as well as a thank you to our audience for your great questions. Sorry we weren't able to get to all of them. As Chris mentioned early on, there'll be more insights coming from this work later this year as we wrap up our final evaluation. As a reminder, please complete the survey that will pop up on your screen here shortly, as it helps with our future programming. So thank you to our panelists and presenters, and again, everyone have a lovely day. Goodbye.